Garcia. I'm one of the sports and knee surgeons here at Orthopedic Specialists of Seattle. Today we're going to talk about a topic that I get a lot, ACL graft options. In general, patients have a lot of different preferences in terms of what their ideas are about this, and also surgeons differ in opinions as well. So we'll kind of clarify some things today and go over all the options. So in general, the first discussion we want to talk about is whether we use a cadaver or allograft, or from a recently deceased person, or we use your own graft called an autograft. In general, the data shows if you're above 35 years old, the cadaver graft has similar outcomes in terms of re-tear rates to using your own graft. And so this is why in these patients, I generally choose a cadaver graft in someone over 35 because it's a much easier recovery with no extra deficits. Now, when you're under 35, this is where it becomes a little bit more complicated, as there's a number of graft options you can use for your knee. And again, these are autografts, so grafts taken from your own knee. We'll start off with the Patella graft. Again, similar to other blogs, I have a diagram. As you can see here, this is the hamstring. We have one that we didn't place here, which is the quad tendon. We'll talk about that in a second. And then here's the patella tendon. So you see we take it from the front of the knee. Again, we take the bone from the kneecap bone, center portion of it, and then we take a piece of the tibial bone, and then we take the center portion of the patella. Again, this is the only graft option that we have that has bone on both sides. This is important because it prevents a complication which we'll go into in more depth during the revision blog we'll talk about later, but you prevent something called windshield wiper that you can get with the hamstring and the quad tendon grafts. Again, this is our strongest graft option. It has a re-tear rate of roughly 2 to 3%. Again, it works best in high-level athletes. You've seen a lot of athletes on TV who've gotten this type of graft, and also if people like to do high cutting sports. This is my go-to graft for most of these athlete populations. Again, you're saying, well, why does everyone get this? Well, not everyone needs a graft at this level. Again, most of the time, hamstring tendon or quad tendon will work quite well, except for these certain patient populations where there's a significant difference. Again, there's also a trade-off. So while you have all the benefits, there's certain patient populations that don't do as well. And these are the ones that have anterior knee pain or a history of kneeling pain. And in these patient populations, if you do this graft, you can actually make it worse. And so these people would consider doing a quad or a hamstring graft. Again, also, it's technically more challenging than the other graft options, and this is why a majority of the community surgeons tend to lean towards the other graft options. In my practice, given the level of athletes we take care of, I tend to lean towards doing the patella graft, but I always leave it up to the patients, and again, I'm proficient in all the graft options. Next, we'll talk about hamstring tendons. Let's go back to the diagram that we looked at previously. This is patella tendon. We talked about this before. This is the hamstring tendon graft. As you can see here, we take it from the side. You have 3 hamstring tendons that we use. We take 2 of them for the actual graft itself for the ACL reconstruction. This graft is slightly less complicated and has something slightly less, such as no mismatching, and so it tends to be a choice for more community surgeons because of this ease of use. Overall, the comparison of patella tendon graft versus hamstring tendon graft, hamstrings have around a 2 to 5% higher failure rate. This is why in general I like to do the patella tendon graft, though this is only for high-level athletes when this comparison comes in. Another concern is patients complain of pain on the inside of their legs with high exertional running or some mild weakness. Now, this does not happen in everyone, but it's something to note. Again, it's important that patients understand the risks and the benefits of this graft option. In general, most patients under 35 do quite well with this type of graft, and it's another reason why it's done so commonly. We perform this graft in patients who have also restrictions from patella tendon grafts, such as I mentioned before, with anterior knee pain, and in these types of patients, this is an excellent option. There are 2 other ways that we can improve the graft re-tear rates to lower them from that 2 to 5%. The first is there's some studies that have been out there for a number of years that show if your graft is larger than 8 millimeters, you actually do better. Now, if you just take the graft and do a standard preparation, you'll only get an 8 millimeter graft about 50% of the time. And so when I do the ACL reconstructions, I have certain tricks that I use in the preparation to make sure that almost every one of my patients has a graft larger than 8 millimeters. The second thing we can do is this is even newer technique called internal bracing. So what we do is we take a collagen impregnated suture and we place it through the center of the graft when we prep it. And this acts as a suspension bridge to protect the graft while it's healing for the first 3 to 6 months. In addition, it adds structural support. I like to do this as there's recent data that shows it improves the re-tear rates, and furthermore, there's very little or no problem by doing it and adds a significant benefit. The next and final graft we'll talk about is quad tendon autograft. So I'll show the diagram. Here's the patella tendon. The quad tendon is the upper portion that connects to the kneecap on the top. We take the center portion again of that, but do not take a bone plug for this. This has been done in Europe for around 10 years, but has just recently gained popularity in the United States. Only around 5% of grafts done in the United States for ACLs are quad tendon autografts. The reason being is that most surgeons don't feel comfortable with this option or have not heard about it, and patients have not heard about it and generally don't request it. In general, I find it the perfect combination between a patella tendon graft and a hamstring graft. It's more robust and thicker than a hamstring graft, but doesn't have the potential downfalls of anterior knee pain with the patella tendon graft. The head-to-head studies show that between hamstring tendon and quad tendon, the quad tendon is significantly lower re-tear rate. Still, for my patients that are high-level, high-cutting sport athletes, I tend to lean towards patella tendon graft still. But if patients have contraindications for patella graft or prefer to not have a patella tendon graft, I tend to lean towards this graft option. Overall, I've been impressed with the results of my recent quad tendons, and I continue to find more indications in my practice for this ACL reconstruction graft. Another option we can, and what's nice about this graft, is I can use that internal brace we mentioned before for hamstrings with putting that collagen impregnated suture in between. There's no risk to this part of the surgery, but it adds benefit in terms of adding structural support for the first 3 to 6 months as your graft gets stronger. As you can see, you have a lot of options, and it can be quite confusing. This is a difficult algorithm that we have to think about. 1, you have to think about activity level for the patient. 2, you have to think about the age of the patient. And 3, you have to think about the sex of the patient. And all these come into play in my decision-making process. You want to make sure you go to a surgeon that feels comfortable with all graft options and can customize the approach for each patient. If you or your friend has an ACL tear and wants to find out more information, visit my website at www.grantgarciamd.com for more information, or make an appointment or consultation at Orthopedic Specialists of Seattle. Thanks.